medication use. All right, here are the CME points. So let's start. What is a conjunctivitis? So just like any other itis, it's an inflammation of a tissue, which is conjunctiva. Conjunctiva is a clear tissue that overlies the eyeball as well as the eyelid's inner side. We have two main types of conjunctivitis. One side is the infectious ones, the other side is the non-infectious side. So the allergic conjunctivitis is the most common type that we see on the non-infectious side. Lignes, it's a very specific diagnosis, very rare, just like Steve Johnson, just like PN or MMP. I won't be talking about those parts. Mainly we'll be talking about allergic conjunctivitis and infectious conjunctivitis. Let's start with the allergic types. We have four types of allergic conjunctivitis: seasonal, perennial, vernal, and atopic conjunctivitis. The most common one that you see, and I'll be discussing today, are the seasonal ones and the vernal ones. So what is a seasonal allergic conjunctivitis? You see a kid coming to you which has teary eyes going on for a couple weeks, couple days. You can almost feel like they're having difficulty breathing. They're about to sneeze. The lower lids are swollen, just like you see in the picture, and they usually have form of an irritation or itching. You see that those kids rubbing their eyes a lot, and that's the type, most common type we see in our daily lives is the allergic conjunctivitis. It recurs a lot. Most of the time, we treat it with topical antihistamines and sometimes oral antihistamines. Usually, they respond very well to the treatment. There is an increasing incidence of this. I want to quickly tell you about the allergic conjunctivitis. Eye rubbing, we don't really want in kids. Constant eye rubbing can cause astigmatism and keratoconus. Those two things can be corrected with glasses and special form of contact lenses. However, that's not very comfortable to treat in a small kid. So we know that early childhood eye rubbing can cause eye problems after teenager ages. So we don't want kids to rub their eyes a lot. If you see allergic conjunctivitis, start the treatment. There are a lot of over-the-counter topical treatments. If one of them doesn't work, try another one. You'll find the one that works. And usually this goes very mild and responds to treatment very well. The second part, this is the difficult part that is also difficult for me to treat. It's the vernal conjunctivitis. This is the more severe form of conjunctivitis, and it affects the cornea. In the lower picture, you see inflammatory membranes and also inflammatory lesions forming on top of the cornea. This causes a lot of irritation, and this starts affecting the vision. And if this moves all the way to the visual axis, it can cause significant visual impairment. So these patients are, require prompt care and prompt treatment. And these patients, they usually have a form of atopic history. Their eyes usually gets worse in the spring. Almost all of my patients are having a recurrence right now, and half of the calls I get daily right now is about patients with vernal conjunctivitis. If you have an allergic conjunctivitis patient and is having too many symptoms on and off that's lasting over a couple of weeks up to months, then you should suspect the vernal conjunctivitis. These patients require an ophthalmology evaluation because most of the time we end up treating them with topical steroids. As you all know, in your daily practice, steroids are sometimes medications. They treat a lot of things. They make you feel good. They improve a lot of conditions till they don't. That's one of the problems with these topical steroids as well. The kids, they respond very well to topical steroids, the kids with vernal and allergic conjunctivitis, but there are two main side effects that we see in kids. The first one is increased eye pressure, aka glaucoma, and the second one is the cataracts. Usually the eye pressure increase or the glaucoma responds very well when you stop the medication, but once you develop a cataract, there is no going back from there. And I have to tell you that in the past 18 months, I saw 8 patients who have been using topical steroids over a year. That is not a good care. As soon as you can, you should taper and stop the steroids, topical steroids in these patients. And if you have to use them, which is very, very rare, you have to do it under the care of an ophthalmologist. Also, this vernal conjunctivitis cannot always be explained by the allergen exposure. So what about the updates for the vernal conjunctivitis? Now we have 2 medications that actually we use for long-term control. One of them is a topical cyclosporin, and the other one is a tacrolimus gel. But again, I want to remind you, no long-term steroids. And, you know, most recent studies about the use of these new medications, topical cyclosporin, now the lower dose one, the one with the 0.1%, has an FDA approval for the use in vernal conjunctivitis. It's not as effective as the 2%. Sometimes I would have to use the 2% one, but regardless, this is our first medication that we select to taper and stop the corticosteroid use. And also, dermatologic tacrolimus use ointment to the eyelids seems to work. This is a off-label use, but I do have a couple patients that I've been using, and the results are looking good. All right, this is also an update. Historically, we used to tell the parents that for the vernal conjunctivitis, the systemic treatment is usually not enough. But now I'm seeing more and more studies, and I'm seeing on the patients myself as well, the immunotherapy is helping with the eyes as well. So I started to send more patients to our allergy team more than I used to, but it seems to be increasing the efficacy of the topical medication use. All right, one thing, this is an update that I have to discuss with you. We have a new medication, rather new medication that the dermatology folks use for atopic dermatitis. It's the only biologic medication approved by FDA, dupilumab, and that is causing very, very severe conjunctivitis, very severe ones. Remember, I told you initially for allergic conjunctivitis, it causes mild redness, mild discharge. Usually kids are not bothered by it too much, but we're going to be discussing today about adenovirus infection. The one that we get from dupilumab use, the Dupixent use, can be as severe as just you see in the pictures and can mimic adenovirus. When I see my first patient, the redness and the swelling and the discharge was so severe, I thought the patient had very severe adenovirus. And this, unfortunately, only responds to topical steroids. And again, we don't want to use topical steroids for a very long time. Topical immunomodulators, tacrolimus and cyclosporin, is effective. There are some case series and case reports that it's effective. But again, it's an off-label use, and you would require a PA to use them for the Dupixent use, and that takes time. So right now, if the patient has this severe conjunctivitis, I start the steroids, I taper the steroids. If this repeats a couple times, I usually talk to dermatology folks about, switching potentially different medication, systemic medication, or stopping this medication. All right. Also, I wanted to remind you there are other couple drugs that can cause conjunctivitis. I don't know how common and how often you use those, but proctolol and the penicillamine can cause conjunctivitis as severe as dupilumab as well. All right. This was about non-infectious part. Now I want to discuss about the infectious part. This is also part that you see a lot very commonly. Mainly viral, bacterial, fungal, and parasitic. I'm not going to be talking about the fungal and parasitic because they're very rare, but I'm mainly going to be talking about the viral and bacterial. There are 2 reasons why I'm going to be talking about viral a lot, because it can have very devastating consequences, but we'll discuss that. So adenovirus is the one that I want you to all take home from today's exam. It can cause very severe conjunctivitis. I'm going to show you a lot of pictures, but it can be unilateral, it can be bilateral. It can start as unilateral and jump to the other eye after a couple of days to weeks. It can cause pharyngitis and fever. And when you see severe swelling plus mild fever as a pediatrician, the first thing that you think is preceptocellitis. So this can even mimic a preceptocellitis, but as you know, you can expect this is not going to respond to systemic antibiotics just like a preceptocellitis does. What will we see? Periauricular lymph nodes, adenoid lymph nodes. This is highly contagious. That's why I want everybody here to know very well about this. And it can cause some visual impairments. It is not very severe most of the time. That corneal involvement and visual impairment responds very well to the treatment. All right. This is the picture that you're seeing right now is a mild adenovirus conjunctivitis. This patient can be just, you know, as a pediatrician, when you don't have the instruments that I have, just can just look like a allergic conjunctivitis. So, you know, there is mild lid swelling, there is mild redness. The first thing to check, the most common thing to check that's going to help you a lot is the lymph nodes. If the allergic conjunctivitis will not cause any lymph nodes around the ears. All right. However, it can cause severe bruising of the lids and swelling. Again, you know, if you're seeing a bruising in the eye, if especially unilateral, do not think of raccoon eyes. The first thing, you know, if there's a significant tearing from the eyes, significant light sensitivity, think about the adenovirus infection first. This is the corneal involvement. I'll be discussing that a little bit. These white spots that you see on the cornea, they're called subepithelial infiltrates. They can cause some discomfort. They can affect the vision, but they usually go away on their own. So this is the most common viral infection of the eye. Affects 60 million people in the United States annually. It's a major cause of loss of work. And has a very big economic impact, and it's also a very big problem for the hospitals. We will be discussing at the end as far as the healthcare force as well. So the transmission person to person by tears, oral or nasal secretions. You can get this from the contaminated surfaces. We're going to discuss about how to clean the exam rooms when you see a suspected adenovirus patient. There can be an incubation period. That is, you know, one of the biggest problems, all kind of infections, that it can be contagious before the symptoms develop, and you have the whole school, whole hospital develop an infection before you even know about it. All right, how do we get it? Usually you have someone sneezing, you have the exposure from another person, your mucous membranes, mouth, conjunctiva, and then you get the local infection. Most of the time it stops there after the local infection. Of course, it is still contagious. And then it can spread to the middle ears, GI tract, still contagious. And then uncommon, but it can have even meningitis and lower GI tract infection and bronchitis. All right, we have a couple of types of it. One type is acute follicular conjunctivitis, subgroups. You all know about this, the serotypes. There is another one that causes the fever and pharyngitis, pharyngoconjunctival fever. But the one that I want you to know most about is epidemic keratoconjunctivitis, also the serotype 8. All right, what about the clinical features? I'm going to show you a lot of pictures, but again, usually there is abrupt onset. It can start unilateral and it can jump to other eye. You're going to have a lot of serious discharge. It's going to be a significant lymphedema and again, lymphadenopathy. You're going to see conjunctival hemorrhages. I don't know if you can see that with pen light. I'm going to show you what the pictures are. They're almost unique to adenovirus conjunctivitis. Follicular conjunctivitis, you may not be able to see that with the pen light, but the membranes are also very specific. And the rest is the corneal part. It can take weeks to resolve, and it is highly contagious again. All right, you know, we start with some mild patients. Again, bilateral, both eyes, both patients, mild, moderate lid edema, some discharge, some discomfort, some injection in the eyes. And now we still have on your left side a severe discharge, more severe injection, and some eyelid injection as well. Let's move forward here. You can see the hemorrhages. They're closer to the lid margin. Do you see the small round things? And you can see the follicles here, early follicle formation. So, there are two types of elevations that you can see on the eyelids. One of them is called papilla. The other one is called follicles. They are very difficult to tell apart from the pen light exam. But if you are seeing this severe lesions all over the upper lid, this much of a swelling, this has to be either a very severe allergic conjunctivitis or very severe adenovirus. Again, more edema on the eye, more injection, and follicles again. You can see the follicles here all over the upper lid. You can even see here how they shine through the light. The follicles elevation of the conjunctiva. And again, you can see severe follicles here. And then there is an early membrane. If you're seeing a white membrane, that membrane needs to be peeled. In the kids, I know it's very difficult. I get a propicane or tetracaine. I put it in the eye. I get a Q-tip, cotton tip, and just rub over the eyelid till I can remove them. They can bleed a little bit. That's okay. But if you don't treat the membranes, it causes a lot of discomfort, and the redness is never going to go away till you remove the membranes. And again, this patient has a fully developed follicles. If you're seeing something like this is not a minor viral conjunctivitis. That's what we most commonly see, or a minor bacterial infection. This is going to be, if it's a follicle like here, it is going to be adenovirus, or if it could be still a very bad vernal or allergic conjunctivitis. And again, there is an early keratitis here on the right side. You can see that small white spots on the cornea. So I always, when a pediatrician calls me, unfortunately, the way my schedule works, I cannot see those patients with conjunctivitis very often, very frequently. I would say very quickly. And I usually tell my pediatrician that calls me, hey, get a culture. You can always culture that. You can get a viral culture. You can send it for serology. You can ask for antigen detection. But that's going to help us a lot with the diagnosis. So let's talk about the treatment of that. So is there a worldwide approved treatment for adenovirus? Unfortunately, there is not. There is no treatment that I'll be discussing to you. It is going to make wonders on the kids. Basically, it is going to go away on its own. And our main responsibility as physicians or providers is going to be stopping the spread instead of treating the condition, unfortunately. Common antiviral medications, cidofovir is toxic to cornea and ocular surface. Trifluridine is not shown to be effective. Ganciclovir, there are only case reports that show that it's effective. Again, this is one of the reports. It shows that the recovery, instead of 18 days, it could be 7 days. The subepithelial infiltrates, these are the complications that cause the visual impairment, could be seen less. But ganciclovir can be tried. The gel form, the ocular, or the one that we use for the eye surface. Also, the other drops, the corticosteroid drops, just like the allergic conjunctivitis, that helps with the symptoms. But the problem is you gotta stop them at some point. And a lot of the patients, when you stop or taper this corticosteroid drops, the symptoms comes back. That's why in my daily practice, I try not to use the corticosteroids unless their patient's vision is highly affected by the infection. And then even if I use them, I try to stop them as soon as possible. But if you don't want to have a recurrence of the symptoms, you would have to stop it very quickly. I'm sorry, very slowly, very slowly. So NSAID drops, not effective treating any of the symptoms. Cyclosporin, there are more and more case reports and studies that shows that they could be beneficial. But again, the problem with the cyclosporin is the price. It's expensive. The drops are expensive, and this is an off-label use. Also, I forgot to tell you about that. The corneal involvement, corneal lesions are uh, reactive lesions. They are not the lesions of the virus itself. They're inflammatory deposits. That's why the steroids and cyclosporin helps with those subepithelial infiltrates. Tacrolimus also, it's early on. People started using it. It could be affected. Before I start using on the kids, I should see more evidence that it's not toxic to the surface. It's not causing any other problems in the adults. All right, again, prednisone acetate steroids, when it's compared to placebo, it improves significantly in the reduction of the symptoms. But the problem is when you stop it, when you taper it, the symptoms can come back. And then instead of dealing with this in 2-3 weeks, you end up using a couple of weeks of steroids and taper the steroids, and then having another symptom after 2 months or 6 weeks after the start of the symptoms. And then you have to wait another 4-6 weeks for this infection to go away or the symptoms to go away. All right. Again, I only recommend them if there is a severe membrane formation or if it's severe corneal involvement. So the most common conversation with me and the parents when I see this is about the likelihood of the second eye involvement, so they can be prepared for that, and also how to prevent the transmission. So I try not to see them again because it's highly contagious. I don't want my whole team and whole patients waiting in the waiting room to have adenovirus conjunctivitis, so they come to office and leave very quickly. Everyone in my front desk and my team knows that if patient comes with pink eye, we room them ASAP. They never leave the same room. I examine them. The workup, the examination is done in the same room, and we try to send them home as soon as possible. What do I recommend them? Probably infectious disease folks, can give you a lot more information than I can about this. But if they are sharing, they're not going to school, of course. They're off to school. That's one of the biggest problems coming from the parents. They want to send the kid back to school as soon as possible. They're not going to go to school till the symptoms, the redness and discharge is fully gone. Fully gone. So the first thing, they're not going to school. The second thing, if they're sharing the room with another sibling's kids, not anymore. They're not using the same cutlery. They're not using the same towel. They're not using the same pillow, anything with the rest of the household. So they are separating everything, just like how we did in COVID. Basically, I tell them to put the kid into a room and they can play the video games. I know we try to limit the screen time. They can play the video games. They're going to get bored, but they're going to spend their room as much as time as possible without contacting anyone else. All right. Again, in the office, if you see that as a pediatrician, try to segregate them to one room. Never use the instruments, the equipment they use on that kid with another patient until you fully sterilize them. Disinfect hands after each patient contact. And remember, we do touch our faces, our rest of our body all the time. So disinfect your hands every time you touch the kid. Do not wait till they leave the room. So every time you handshake the parents, you touch the kid, of course, use the glove, but still disinfect your hands. And I want you to pay attention, ethyl alcohol, 70%. Okay, and disinfect all the instruments with chlorine bleach, ethyl alcohol, and sodium hypochlorite. And again, avoid handshaking with these patients. So I want you to remember I was when I told you about the subtypes, I wanted you to pay attention to serotype 8. Again, with hand sanitizer that we use has 63% ethanol, and after 5 minutes, it was the virus was still active. So when you have the pro in your office, you don't think you're off the hook. Okay, be careful. And the serotype 8, is the one that causes the epidemic type. All right, again, this is a unique patient. Most of the time, more commonly be seen both eyes, but this patient has unilateral. You can tell that this patient has very severe redness, very severe redness. This is not something that we expect in allergic conjunctivitis. That's not something that we expect with minor viral conjunctivitis or in bacterial conjunctivitis. If you are, this is not a kid, but if you are seeing a kid with marked redness that lasted long time, uh, and with this much discharge, the first number one thing I would be suspicious would be adenovirus, conjunctivitis. The other two, which I'm going to discuss at the end, that you should be very careful is, especially if it's unilateral. If it's unilateral, foreign body. Kids can always have a foreign body in their eyes. They may not recall, the family might not recall any trauma, but I don't remember how many times I removed a foreign body from the eye for a referral for conjunctivitis. So I move the eye, I pull the eyelids and I look through the fornices very truly every time I see a conjunctivitis. Of course, very quick and not with your without a glow like this person does in the picture. And the third thing is the herpes infection, herpes keratitis. It can cause very severe redness. Again, unilateral patients. If you're having a unilateral marked edema, redness of the eyes, tearing, put a fluorescein dye if you can to the eyeball to check for herpes. I'm going to show you how to do that at the end. And also foreign body. Make sure there is no foreign body in the eyes. All right, another patient, very severe redness, again, very severe injection, lid edema. Another one, very severe redness, very severe injection. And, this person, gentleman, cannot even open his eyes. Okay, again, more. You see the hemorrhages here? If there is no trauma, hemorrhages here, all over here, there are hemorrhages here. You can see there are hemorrhages here and here. If you are seeing the hemorrhages in the conjunctiva, I would be more concerned about adenovirus. Again, couple more examples, severe hemorrhages of the conjunctiva. This is when you flip the upper lid, lower lid, and also you can appreciate severe discharge here as well. And it's serious. All right, again, severe chemosis, severe edema of the conjunctiva, more examples of redness and hemorrhages and injection. Okay, here are the examples of the membranes. When you see this, you have, if you're comfortable, you have to clean this with a Q-tip. If you are not comfortable, you have to send the patient to me to clean this. Membranes, even more dense membranes. And if we get to this point, these membranes are going to leave some scarring. And this is more corneal involvement, as you can see. This is a microscopic picture, obviously. All right, again, treatment of major keratoconjunctivitis is corticosteroid drops. If it's remove the membranes and make sure you inform them about the secondary involvement and the prevent transmission. I put those the reason for again for a reason. All right, you see that how it improved with the corticosteroid drops, and these are the ones that they peeled the membranes, and you can see there is some scarring here, there is some scarring here, there is some scarring here. These are the subepithelial infiltrates. All right, so what are the distinctive signs of adenovirus conjunctivitis? Lymphadenopathy, follicle formation, membrane formation, diffuse progressive keratitis, and corneal involvement. The last two ones, you won't be able to appreciate them probably, but you can appreciate these first three in your exam. So this is one of the reasons why I wanted to talk this much about the adenovirus. There was an NICU outbreak in Argentina in 2018, and 20% of the residents got conjunctivitis with the certain membranes. They were all, remember, subtype 8 positive. That's the one that spreads and that's resistant to 62% hand sanitizers. And then it lasted 18 days. They had to, close the NICU, and all the high-risk pregnancies were transferred somewhere else. All the babies were transferred to another station. And see, it costed, $200,000 to the hospital in Argentina. I can tell you it's going to cost us a lot more. So that's why, especially in the NICU, we have to be very careful. All right, let's talk a little bit about the bacterial conjunctivitis. This is not very common in the older kids. We see it more common in the smaller kids, especially kids with nasolacrimal duct obstruction, aka the blocked tear ducts. So usually there is no contact history. You can see, whitish, yellowish conjunctival discharge, and there's not going to be any lymph node enlargement. You can still have some otitis, urinary tract infections, most commonly they go together with otitis, and you see a lot of patients, they have ear infection and some white yellowish discharge coming through the eyes. But the etiology, Haemophilus influenza is the most common one. That wouldn't be a surprise to you, followed by pneumococcs. These are all the available treatments. That's something that I commonly ask from the pediatricians. Do you have any preference? No, I don't. You can use any of those drops or ointments, whichever you find. All right, one more thing, neonatal conjunctivitis. This is, I would call, an ocular emergency. This patient needs to be sent to emergency department, requires a workup, and this usually follows the infections, the local infections on the neighborhood or in the town. And you have to do gram staining, gamma staining. You have to rule out bacterial viral cultures. You basically have to do all these patients. Of course, there are ones that are high risk, low risk, but some form of sepsis and meningitis workup. And you have to direct the treatment according to etiology. All right, the last thing, I wanted to discuss about is about unilateral, long-lasting redness, conjunctival injection, discharge, and light sensitivity. We have to rule out herpes, herpetic keratoconjunctivitis. Primary infection is also follicular conjunctivitis. You can see skin vesicles. It makes your life very easy. They would require a form of treatment, most likely an oral acyclovir. And again, this is the most important part, is putting a fluorescein dye and checking with the cobalt blue. I think most of the practices should have a direct ophthalmoscope. Most of the direct ophthalmoscopes, they have the cobalt blue filter. If you switch the node on the head and you just put a fluorescein drop to the eye or fluorescein strip to the eye, and you check with the cobalt blue, if you're seeing these lesions, the left one or the right one is obviously more severe. This requires an ophthalmology referral, and that patient needs to be on acyclovir ASAP. And unfortunately, you all already know herpes recurs. So there is also something that you can have in your practice, in your mind. If there is a patient was diagnosed by an ophthalmologist for ocular herpes, herpetic corneal or conjunctival involvement, and if they call you with sudden onset redness or discharge or light sensitivity, I would see them right away. And if they have the redness, I would start them acyclovir ASAP. All right, two other things I'm going to talk very quickly about it is the first is the COVID conjunctivitis. COVID can spread through the conjunctival discharge. So that's something that we have to be careful. And there is a very long virus shedding time. The conjunctivitis, my part, the eye-related part, is usually very self-limiting. I never had to start a medication to a person with COVID conjunctivitis. I never seen a corneal involvement. It's a very self-limiting infection in the eyes, but the problem is it's contagious and it can cause the spread of the COVID. And also Zika virus, we are very familiar, you're all very familiar with the congenital virus infection, but the non-congenital Zika infection can cause conjunctivitis as well. If you have a patient coming from a risk country, the countries that has Zika virus, it could be a good idea to check and think about that and potentially send some virus cultures to the lab. All right, thank you all. I can take the questions now.
All right, thank you, Dr. Guner. We have one question. So with bacterial conjunctivitis, do you recommend adding a steroid with the antibiotics? So I guess there's Tobradex or Ciprodex, different ones like that.
So that's a very good question. Again, if you add the steroid, the patient is gonna recover from the symptoms very quick, but can have high pressures. It is shown to cause increased eye pressures even in 2 weeks of use. So, and you wouldn't know in your office if the kid is having high pressures. I mean, you know, if you're just going to use a week or 10 days, it could be an option. I'm not against that. But if you're sure the patients are going to continue using them as a dry eye medication, that's something that we see. They get a drop from the pediatrician or from a, pharmacy. They think that's good for all kind of pink eye discomforts, eye symptoms, and they keep using it for 6 months and 8 months. If you're going to use it, Tobradex as steroid plus antibiotic combination, make sure the patient is not using them or longer than 2 weeks. And the second thing is make sure the patient doesn't have herpetic infection, because if the patient has herpetic infection, it's gonna make it significantly worse. So if you did the first aid check and if you're sure there's no herpetic lesions, there's no risk of herpes infection, you can start the Tobradex and make sure that you don't use them more than 2 weeks.
Okay. And another question, with the eclipse, did you see any kids losing sight because of looking into the eclipse? And 1, and 2, what is the pathophysiology with that?
So yeah, that's a good question. I was off last week for 3 days, so no one called me about a patient losing the sight, sudden vision loss. But so I have not seen anybody yet so far. The effects of it can be seen weeks after. So the pathophysiology of that is, so we have our pupil. The reason why we have our pupil, but our iris, is to limit the light coming through your eyes. Inside your eyeball, you have your retina cells. Retina cells are the receptors that takes the light and process it. Behind the retina, you have a tissue called RPE, retinal pigment epithelium. This epithelial cells, they emit the light. They emit the light significantly because they have melanin in them. So our pupil works to limit the light going to your eyes, because too much light, exactly just like you have a magnifier, it causes fire. It burns. Because we all have magnifiers in our eyes. Our lens helps us focus the light. And just like the magnifier, and that tissue behind the retina emits the light, excess light, and if it gets too much light, there's too much free oxygen radicals, and it kills the cells there. And this is how you lose your vision. And the problem with the eclipse is that lights that always exist in the sun, but we don't look at the sun directly in our daily life. You cannot do it. It burns your eyes. But when there's an eclipse, the UV light is still there, but you can look at the sun, and that's how you get your eyes burned. So actually, eclipse is not causing any abnormal lights. The abnormal lights are always there. It's just we're not looking into them.
Okay, perfect. And do you have a go-to allergic conjunctivitis drop that you use?
So, yeah, that's a very good question. So they're probably asking about the over-the-counter ones. Over-the-counter ones, I usually like to use the olapatadine. So the commercial names are Pataday or Patanol. So that the other ones, I feel like they cause a little bit more irritation when you put the drops in. That's why I like to use the olapatadine. And also olapatadine has a version in the market that can be used once a day. With this, most of the other drops are used twice or 4 times a day. That's also, you all know in a 2-year-old, 1-year-old, putting a drop into the eye is not very easy, even a 3, 4, 5-year-old. So when we can use a drop once a day, parents prefer that significantly more than the others.
Okay. And last question, can you talk a little bit about laser injuries to the eye?
Okay.
Yeah.
Yeah, that's the same thing. That works the same way the eclipse does. There is harmful light rays in your eyeball. Your eye, the cells, they can emit those lights till some degree. And then if you get more light to your eye, you get the free oxygen radicals. They start causing injury to the cells inside your eyeball. And the most important part of your vision is your central vision, and that is where you look directly at things. And if you look at the laser, depends on what type of laser light they have in the laser itself, you can burn your eyes, basically the same way the eclipse works.
All right. All right. Thank you, Dr. Guner.